Hi, everyone. Welcome. Nice to have you joining us for this webinar. We're going to get started in just a moment here. See everyone trickling in. So we will start in just another minute. Again, hi, everyone. So grateful to have you here. I see everyone's starting to jump in. We will wait another moment and then go ahead and officially get started. But good to see everyone. I see some folks chatting already from Maryland, St. Louis. Welcome, Pennsylvania. Good to see you. Hello from New York, Georgia, Wyoming, Florida, Tennessee, Michigan. I love seeing everyone join from across the country. This is wonderful. More DC and New York and Canada. Wow, welcome. Georgia, New Jersey. Fantastic. And Texas too. Well, on that note, since we are speaking about states, I will share that myself and my two colleagues who are hosting today's presentation, we are in South Florida. And as many of you know, there is a hurricane outside, not too bad on our coast here in Palm Beach County. So we are still able to virtually connect with you today, but we just wanted to let you know in the event that we do have some tech-related issues, we have some backup plans, so everything should be okay. Please stay on the call, and we will fix it as quickly as we can. So on that note, we will go, oh, yes, and I see someone from Fort Myers who I appreciate you joining today. I know your coast is certainly feeling it, so welcome. We will officially go ahead and get started. So thank you once again for joining. If we're not familiar with each other, my name is Amanda Bassos, and I am the Regional Resource Director for Karen, based here in South Florida. And today's webinar topic is From Isolation to Connection, How Wellness Leads to Greater Mental Health Outcomes. Now, as a reminder, we are conducting today's webinar format in format, which means that participant microphones will be muted. While we can't hear or see you, you can hear and see us. So during the presentation, feel free to utilize the Q&A feature to ask questions, the chat box. We welcome engagement just the same. Now, depending on the volume of questions that we receive, we may not be able to get to everybody's before the end of the hour. In the event that happens, we will have someone from our team follow up with you directly, usually within the next week. Additionally, the slides and recording of today's webinar will be emailed to you within 14 days of the program being completed. So today's presentation is eligible for 1 CE credit, and we would like to thank our educational partner at CE Learning Systems for helping provide these credits through co-sponsorship with the American Psychological Association. Now, please note, in order to receive your credits for today, you will need to be on for the entirety of the program and complete the post evaluation. So a link will be emailed to you directly after today's presentation from CE Go. You'll complete that. Once that's submitted, you'll have immediate access to your certificate of completion. On that note, today I'm proud to introduce our presenters, Anna Green and Stuart Warren from Karen, Florida. Anna Green is the family therapist for Karen, Florida, the mental health program. Her primary focus is on providing family members with support and education through family sessions, joint sessions with the patient as well. Anna gives families the tools and information they need to support their loved ones through mental health struggles. She has more than 7 years of experience as a psychotherapist in the education, addiction, palliative care, and mental health fields. Anna is trained in MBT, mentalization-based treatment, and art therapy. Now, before moving to the US from the UK, she worked in an adult mental health inpatient hospital with patients diagnosed with psychotic disorders or borderline personality disorders. Next, we have my colleague, Stuart Warren. And Stuart is the clinical supervisor of the mental health program at Caron, Florida, and he oversees clinical services and also provides care to our clients. He is responsible for developing, managing, and providing the services needed to help clients learn the skills to manage their mental health and improve their functioning so they can lead meaningful lives. Now, before shifting into his current role in June of 2022 this year, Stu was an intensive outpatient and primary therapist at Caron, Florida since 2019 and managed a caseload and provided individual and group therapy as well. Stuart believes strongly in the importance of family involvement in treatment and practicing principles of trauma-informed care. Before coming to Caron, he provided treatment services for mental health, substance abuse, and domestic violence at another Florida agency. He was also a caseworker for the Washington, D.C. Department of Family Services. He's a licensed clinical social worker in the state of Florida as well, and he's trained in dialectical behavioral therapy, DBT, and EMDR therapy. Now I will hand the presentation over to Anna and Stuart to get us started. So thank you all for joining us today.
Thanks, Amanda. Welcome, everybody. So as Amanda mentioned, my name is Stuart Warren. I'm the clinical supervisor of mental health down here at Caron, Florida. So thank you guys for taking some time out of your day to join us on this webinar. Just want to briefly go over the contents of what we're going to be discussing today, so you guys kind of have an outline of what to expect. So in a moment, I'm going to toss it over to Anna, and Anna is just going to provide us with an introduction of what is a social relationship and why they are vital to our mental health. Right? So she's going to go into describing some of those areas and talking about some of the benefits when we talk about the importance of those relationships for our quality of life and our mental health as a whole. Then we're going to shift in and talk about barriers. Anna and I are going to share this one. Why might we struggle with social relationships? So we're going to talk about societal issues. We're going to talk about specific mental health diagnoses and some other areas about what are some of the barriers, what are some of the struggles that we have in developing these relationships. And then we're going to shift into solutions. So how can we help ourselves and help others, the people we care about, maybe their clients, family members, friends. And then we're going to go through a summary of everything that we went over today, and we'll wrap up, provide the resources, and also have some time for some Q&A. So having gone over all that, I will shift over to Anna, who is going to take you through the first portion of our programming. So the floor is yours, Anna.
Thank you, Stu. So what is a social relationship? Social relationships are between people who share a common understanding of something. They have subjects or interests or experiences bonding them together. The relationships themselves can be different degrees of emotional closeness or how frequently that you have contact with them. They can also vary and be formed in different environments and be with a range of people. So for example, with spouses, partners, friends, acquaintances, or colleagues. And social connections are then formed from the various social relationships that we have. So why are they vital to our mental health? We are social creatures that cannot survive without social interaction, as it is our human instinct to create social connections. We have a need to support others, to interact, and receive physical comfort. The main function of relationships is to continue human survival and form societies. Some benefits of relationships are that they make us feel like we are never alone, that we are part of a community. Without interactions, a relationship cannot be formed or remain strong. And if we don't experience intimacy, we can experience emotional isolation, loneliness. And intimacy is built from those social relationships. So overall, findings related to loneliness and health have been so well documented that the negative physical and mental health effects of loneliness have been compared to risk factors for mortality, such as smoking, physical inactivity, and obesity. So in addition, we can see that lonely people typically have higher rates of mental health disorders, including depression, anxiety, schizophrenia, and features of suicidality. So some barriers to forming social relationships that we're going to come on to in this next section. Social media, COVID-19 and the impact that this had on everyone, self-esteem and stigma surrounding making connections, and the impact of certain mental health diagnosis on struggles and difficulties in forming relationships, alongside the need to do so, that they are something that we need. So we'll start off by thinking about the impact of social media. As you can see in this graph from January 2022, this is how digital growth has changed. So social media attracts people from all ages, but the younger generations in particular. It is a low-cost, easy, and convenient way to connect, and large parts of our lives have become virtual. Emerging evidence suggests that online ways of relating cannot replace physical interactions, but it does have some benefits and ways to connect with others that we didn't have before, particularly with online platforms. So for those with mobility issues or who are geographically separate, social media is a perfect place for them to connect with people. But people have become more dependent on social media and increasingly isolated. And those who spend the majority of time on social media have been known to lack emotional connections. And by spending less time with people in person, they are likely to have poor face-to-face communication skills and are more used to communicating their feelings in an inauthentic way. And you may have observed yourselves that people are more noticeably glued to headphones and phones and have been known to pretend to notice each other. And I personally find this more often on public transport for some reason. So COVID-19, I'm sure you're all used to hearing this come up, but with regards to this, we had actual barriers and rules to not see each other. We had stay-at-home orders all over the world, and there was no physical contact or locations open for us to socialize in, even our homes. So COVID-19 changed a lot about how we view the world. There was a new threat which made it unsafe to be with people. Some people had to shelter for longer than others due to their own health, making it even harder to start to feel safe being around people again. And some countries today are still going in and out of quarantine, and mask orders continue to fluctuate. But during COVID-19, at its peak, we became increasingly reliant on social media and video call platforms. This was to pass the time and to communicate with people. We even adapted so well onto social media that we were doing weddings and funerals online. One benefit of this period was being able to contact people abroad more easily, or the ability to work from home. But sadly, some contacts and networks were not easy to transfer to an online platform. So this meant that these connections were likely lost. And one of the major losses that we faced during this time of COVID was an absence of spontaneous social interactions. There were none of those moments of getting to know a colleague in the staff room while you're getting your next cup of coffee, seeing someone in the gym or being a regular in a certain gym class with that person. These moments are indirect support opportunities, and there was a lack of this for safety. So self-esteem and stigma. People often have a natural fear of rejection from social situations, that they'll be laughed at, ignored, or something else. There's also an expectation that others will not be interested in talking to them, but that people are likely to underestimate how much others like them after meeting for the first time. People often put down their ability to start and maintain conversations, thinking they'll be awkward or not know what to say, whereas they do normally tend to go better than we predict. So with regards to self-esteem and stigma, we can often be our own worst enemy and our own barrier to being able to facilitate communication. And I'll come on to this in a bit more when we look at solutions later on about how to move forward.
Thank you, Anna. So with that, I want to take some time to talk about the significance of diagnosis when we talk about building and maintaining social connections. And just a quick note on diagnosis, that whenever we talk about a mental health diagnosis, there's always the risk of that becoming a stigmatizing or pathologizing conversation with our loved ones, with ourselves, with anybody who's affected by a mental health condition. And one thing I just want to note as we go through this, that there's a ton of value in having accurate diagnosis and attributing what you're experiencing to a mental health diagnosis. But we always want to be sure with ourselves and with others to view someone with a mental health diagnosis in the context of them as a person, and to make sure that we're taking in that a depressive or anxiety disorder or personality issue is going to look very different based on an individual. And it's just something we want to keep in mind, because that's going to impact the barriers that they have as well as the solutions. So quickly, we know that specific diagnoses, symptoms, and traits can impact one's ability to develop and maintain social connections. I hope to explain that more thoroughly on future slides. Treatment of mental health conditions can result in improvement in social skills and social satisfaction. That's what we're going to be going over in diagnosis today. Anna, you can go to the next slide. So first, let's talk about depressive disorders. So I think depression is one of these topics that we're pretty in mainstream society, or at least getting more comfortable. Some of the ones that you may be here on the side, the most kind of pertinent are major depressive disorder, persistent depressive disorder, perinatal depression, seasonal affective. Bipolar disorders are technically mood disorders, but oftentimes include prolonged periods or depressive episodes. And generally, when we think of a depressed person, we can identify some of these symptoms on the right, which, persistent, sad, anxious, or empty mood, hopelessness and pessimism, irritability, frustration, restlessness. Just a note on that one, a lot of the times depressed people will present as angry, and we kind of miss that because we're expecting to see them as sad or forlorn or withdrawn, but irritability is certainly a component of depression. Anhedonia, so loss of interest and pleasure in things that typically did cause pleasure or were an interest. Low energy, fatigue, thoughts of death, self-harm, and suicide. So one thing just to kind of note is I think oftentimes with a diagnosis like a depressive disorder, we often think of that as something that is in a vacuum, that is stationary, that if you have a depressive disorder, you'll always have a depressive disorder. And that is certainly some people's experience, but it's also important to note that most human beings experience times of clinically significant depression throughout their life. Oftentimes that's environmental, with a divorce or the loss of a job, but depression isn't something that we should categorize as solely present in people with true depressive disorders. I think most of us on this call have had some experience with some level of depression in our lives. Next slide, please. So a note on depression. So I think the culture around depression and the discussion around depression has really inaccurately been discussed in our culture as solely the result of a chemical imbalance in the brain, right? And I think we're all familiar with this. I think if any of us had a loved one who came to us or were experiencing depressive symptoms, one of the first places we'd probably go is to see a psychiatrist. We'd be interested in getting on an antidepressant in order to help our depression. And there's certainly nothing wrong with people who need antidepressant medications. They are very helpful for some people. But really what I want to note and kind of harp on today is that there are actually 9 primary causes of depression that have evidence base to show cause depression in people's lives. And this is built off of Johann Hari's work, who wrote a book, Lost Connections, and has an amazing TED Talk on depression. I encourage you guys to all go watch. He really talks about disconnection from a lot of parts of someone's life. So people who have disconnection from meaningful work, from other people, from meaningful values, childhood trauma, the natural world, from a hopeful and secure future, these are all things that very, very understandably lead to depression. And so we start to shift our lens on depression as not this reflection of, something is broken in your brain, but essentially that you have an unmet psychological need. Hari talks about how we all understand that we have physical needs, right? Air, water, food, right? We also have psychological needs that are listed here that, we really do need to address and treat very similarly to our own physical needs in order to prevent depression, in order to treat our depression. Now, there absolutely are some genetic and biological factors. We do know that depression and anxiety can cause changes in the brain. So if you have depressed ways of thinking, if you experience long bouts of depression, you are more likely to experience depression as your brain kind of adapts to that. And we do know that there is a genetic component to developing anxiety and depression. So it's not that this biological model of depression is entirely accurate. It's just we really want to engage in a more comprehensive view of depression when we start to talk about treating it. And as you can see, a lot of these areas where we do get disconnected from involve other people, right? So as we transition here, Anna, you can go to the next slide. As we talk about social relationships and depression, there's absolutely some really legitimate barriers for here. Oftentimes we think of that depressed person sitting on the couch alone in the dark, as we see here in the picture, or alone under the covers. And these people are just more likely to struggle to engage in social activities. They're more likely to not want to engage in social activities. They prefer to isolate. Even when they do get out and socialize, they have a hard time enjoying those social interactions. And we know from the research that there's a correlation between depressive symptoms and perceived quality of social support. And people who have improved perception of social support have better outcomes. And this is shown through a number of different studies that social support and perception of social support is an enormous component of depressive symptoms. That's also true for schizophrenia and anxiety, but the bulk of the research into depression shows it pretty definitively. And just kind of a side note, kind of a group anecdote in my experience working with people with depression, I think right now we're in a place culturally where so often when we experience internal discomfort, anxiety or depression, we kind of go for like a Band-Aid treatment, right? So we might pick up our phone, we might do the Netflix binge, we might have a glass of wine. We essentially try to distract ourselves with something that produces a good amount of dopamine. And the problem is that it sort of works, right? It feels better in the moment. But ultimately what this does is it trains people to think that when they're engaging in a coping skill, that coping skill is going to work immediately and that it's going to be immediately pleasurable, right? So in working with my depressed clients, I've often noticed that you'll engage in some type of, motivational strategy to get them to do something, which is engage with other people. And their initial experiences engaging with those other people aren't immediately pleasurable. So they'll come back into session after putting themselves out there and they'll say, that was terrible. I didn't have a good time. I was depressed. I was sad. And I think one ways we can support ourselves and support our clients and our loved ones is to really educate them on the fact that as we talk about developing and integrating real change to treat our depression, particularly in the context of developing, a social structure, that takes time. And when it doesn't immediately provide relief and benefits, that doesn't mean you're failing. Right? It means that you're putting yourself in a position to change. And that requires a lot of different support, as I mentioned, when we're so used to, coping means something works immediately and it's kind of pleasurable, right? So that's just a note there with depression. We'll also talk about it with anxiety, that we are a bit in a culture here, and I see it with my clients where we want stuff to work right away. So next slide, please, Anna. So next we can talk about another area I think is relatively commonplace in discussion, in our culture, which is anxiety disorders, right? So we talk about generalized anxiety disorder, social anxiety disorder, panic disorder. So those symptoms are, persistent worry, rumination, obsessive thoughts, difficulty concentrating, uncomfortable body sensations, concerns with judgment of others, problems sleeping. Just a side note about the difficulty concentrating. One of our psychologists here says very often she will see young people, young adults who have a history of being diagnosed with attention deficit disorder or ADHD. And through thorough testing and examination, she'll say, this is anxiety. And I think that is a partial explanation for some of the inaccurate diagnosis for ADHD and ADD in our community, that people are experiencing undiagnosed anxiety. So we can go to the next slide. So depression, like depression, anxiety is often viewed as a result of a chemical imbalance in the brain. Again, this can absolutely be true, but we also look at anxiety in the context of a lot of those areas of depression where we're disconnected from others, we're disconnected from meaningful work, right? So it is not solely a reflection of your brain chemistry. I also really want to help shift the conversation around anxiety. I think anxiety has become super pathologized. It is a very normal part of the human experience, is almost exclusively being categorized as an unhealthy mental health symptom. So anxiety is a normal, useful tool that helps us manage threats, prevent negative outcomes, and stay alive. One of the reasons that humans are on top of the food chain is we have the ability to think about potential outcomes in the future and plan accordingly. We generally don't like that experience of worrying and catastrophizing, and absolutely there are people who have a difficulty controlling that. So it's very uncomfortable for them to be experiencing that place, right? But anxiety gets your rent paid, right? Anxiety keeps you from breaking laws. Anxiety makes sure that you're attentive to the people that need your attention, right? So anxiety is a really useful force, and it helps us to kind of recategorize and redefine what we think of as an anxiety disorder, which I think we oftentimes think of, oh, that means you have too much anxiety in relationship to the environmental circumstances, which is absolutely true in some circumstances. But really, I prefer the definition of an anxiety disorder as when someone's response to anxiety creates more anxiety. And so if we think about an avoidant behavioral loop, right, where someone is very afraid of social interaction, so as a consequence, they avoid social interaction, they actually in turn develop more anxiety about engaging socially, right? So I think we just want to shift the conversation there. We want to educate ourselves and those we care about that anxiety is a normal and appropriate experience. Absolutely, there are times when our anxiety response is overblown and we need support with that, right? But we want to be careful not to pathologize this part of the human experience, because then we start thinking every time I feel any level of anxiety, something's wrong. And sometimes it means something's right. You should be concerned. You should be prepared. You should be thinking about outcomes and preparing yourself. So this is where you may need a therapist or clinician to help you kind of unpack. It's very difficult for people to kind of find that line, right, of what is appropriate level of anxiety versus what is something that might be a little bit more disordered. Anna, you can go to the next slide. So really quickly with social relationships and anxiety, people with anxiety, obviously, they're more likely to avoid social interactions or group setting, right? Oftentimes a big fear of rejection. And anxiety can interfere with the quality of relationships. So if any of you have been in an intimate or personal relationship with someone with an anxiety disorder, it certainly can be challenging for all parties involved. I think when someone is internally preoccupied, when they have a lot of internal worries, uncomfortable body feelings, it's just hard to be present. And a lot of the times they will be with you socially, they will be there physically, but they're not necessarily attentive or engaged or connected with the people that are there. So anxiety is an important component of this picture. And we know that a more positive perception of social relationships is correlated with higher rates of remission in anxiety disorders, as well as overall quality of life. So there's some notes and barriers about the relationship with anxiety. We can go to the next slide. Okay, so personality disorders. So this is another area I wanted to hit on. So in general, personality disorders are characterized by distorted thinking patterns, problematic emotional responses, over or under-regulated impulse control, and interpersonal difficulties. Now, the diagnosis of a personality disorder requires significant and enduring difficulties. So we all may have bouts of our life where stressors and things cause us to have some of the symptoms outlined above. But really someone with a real true personality issue is going to have over a long period of time, those significant and enduring difficulties. So we can go to the next slide. So you guys are probably familiar with a lot of these: borderline personality disorder, avoidant, dependent, narcissistic, schizoid, or histrionic. I'm not going to go super in depth to the specific criteria of all of those. I think, again, this is an area where if you look at our youth culture, there's definitely more use of some of this language. They're quickly to say someone is narcissistic or someone might have borderline personality. I think these are kind of overused in a lot of contexts, but we're going to describe what those are in a little bit. But just kind of generally, they create difficulty with functioning, right? So somebody's ability to maintain relationships, maintain a job, work in the world, function as a human being, that is more difficult when we have progressed or problematic personality features. And one thing I just want to kind of note here is that they operate on a spectrum, right? So again, if we went back to avoidant personality disorder and we thought of the umbrella of what that encompasses, you may have someone on the far progressed end of that spectrum who, for illustrative purposes, let's say it's a hermit living on a hill, right? And he has absolutely no social interaction with anyone. He has designed his life to accommodate that. And just the mere prospect of having any social connection is absolutely crippling for him, so he avoids it. On the other end of the spectrum, where it wouldn't necessarily be disordered, right? It would probably be more in that style or trait range. You might have someone who is generally pretty introverted. They might have a few close friends who they're relatively intimate with, and they can work through, work requirements or other areas where they're required to be social. So it's just important to remember that these personality functions happen on a spectrum, right? And that we're all unique. So it's not like everybody hits the same spot on that spectrum. They're characterized in clusters A, B, and C, which we'll go over on our next slide. And they're often stigmatized, particularly borderline personality disorder. For any of my clinicians on the call, we know that a lot of the times there's a lot of stigma with that. The saying, oh, I don't treat that, I'm going to refer that out. They're treatment resistant. That's something we want to keep in part of this conversation as we start to talk about that. So we can go to the next slide. Great, so we talked about the clusters. So really briefly, so the cluster A diagnosis, this is paranoid, schizoid, schizotypal. This is characterized, all these disorders, by odd, eccentric thinking or behavior. So some of the barriers to social relationships for these people could be paranoia with a schizoid personality, just a lack of interest in relationships. And sometimes there may be odd or socially inappropriate behavior. So very likely to be excluded or judged as weird, or we don't like this person because their behavior is not traditionally appropriate. With cluster B diagnoses, which includes antisocial, borderline, histrionic, and narcissistic, just a note, antisocial doesn't mean I don't like people. It actually generally means I don't like rules. I don't like societal norms. There's more of a power focus with that personality. These are the dramatic, overly emotional, or unpredictable thinking and behavior cluster. The barriers there might be in the context of narcissism or antisocial personality, some struggles with empathy, antisocial or rule-breaking behavior, interpersonal struggles due to emotional lability or emotions being all over the place, difficulty connecting with others, and an unstable sense of self. I encourage you guys, if you're interested in this stuff, to go through and read about these specific disorders, because there is a wide range of nuance. I don't want to, within the clusters, there's a lot of differences, so it's worth exploring if you're interested. Finally, in the cluster C, we've got avoidant, dependent, obsessive compulsive. So these are the anxious, fearful thinking or behavior clusters. So barriers for social relationships are going to be fear of rejection, low self-esteem, avoidance of social interactions, and can also often be rigid and stubborn with their routines. So I just wanted you guys to have a bit of an overview. And Anna, we can shift to the next slide. Where, when we talk about personality and what that means, I like to think of the personality as almost like your immune system for your psyche, right? So we talked about those psychological needs earlier when we were talking about depression and some of the barriers there. And so your personality, to a large extent, functions to help you survive and get your psychological or perceived psychological needs met, right? And that's through your own experiences with yourself, what do you feel about yourself? But the word survival is something that I really want to go through this. So this is adapted from Pete Walker's work on trauma typology, which I think is fascinating, where he kind of goes through some of these biological survival styles. So we all remember from, Animal Planet or any of those biology shows from, second grade biology class, the idea of fight or flight, right? And we also have these other styles of freeze and fawn. And what Pete Walker outlines is essentially how our personality style can be correlated with our survival style, right? So if we look at like a fight style personality, when stressed, when looking to be safe, when looking to build a relationship, the fight style is power oriented, right? Safety in relationships through power, control, and aggression. So oftentimes this is a person who grew up in a household, right, where they realize that I basically only have me and I need to be in a position of power in order to be safe. So that's oftentimes like that narcissistic or antisocial personality style. They're attempting to survive through that personality style. It's a really important note. They're attempting to navigate other people. So with the flight style, this is the mover, the doer, the perfectionistic, the obsessive compulsive, the workaholic. I imagine we have some on this call, right? Who, you get home from work and you clean the whole house, right? It's very difficult for you to sit still. Sitting still might just make you nervous, right? So this is the type of person who the way that they remain safe is they have a control-oriented personality, right? So they're constantly looking where they can create order in a world that doesn't have too much order for us, right? The freeze response, this is more dissociative, withdrawn, or disconnected, right? So this is the person who's determined that they can't control their environment, they can't control people outside of their environment. So the way that they cope with that is they essentially pull away from the environment. They come within. And we're going to talk about a little bit this more when we talk about the nervous system here in a little bit. And finally, we have the codependent people pleaser, the fawn style. So kill everybody with kindness. And that's the mantra of I'll be okay if everybody's happy with me, right? So people who grew up in turbulent or scary homes, they learn to appease mom, they learn to appease dad, try to create safety, right? And that slowly becomes a part of their personality, right? So what's interesting is that a person with a relatively balanced nervous system and personality makeup, they're able to access these 4 personality and survival styles pretty readily. They're able to, say, oh, in this situation, I fight. In this situation, I freeze. But oftentimes, as I mentioned, trauma in childhood creates an over-reliance on 1 or 2 of these survival styles, which can present as a personality disorder. Remember, personality disorders, those traits are rigid, they're inflexible, the environment changes, but I struggle to, right? And we can look at this through this context that this person, due to their childhood experiences, got really, really good at a couple different strategies because it kept them safe at that time. Now they come into adulthood and they don't have access to this wide range of skills, right? So they may be fighting with everybody, right? Well, that doesn't work, right? And that's where we oftentimes see a personality issue. So I thought that that would be helpful as we start to segue into solutions, because we definitely want to have this really solid education and orientation in, what are people doing when they're interacting socially, and how are they trying to remain safe and meet those psychological needs. So with that, I'll transfer it back over to Anna to talk about solutions.
Thank you, Stuart. So with solutions, I'm going to start off by looking at solutions that we can do for ourselves and also things that you can encourage other people to do for them. So here's a few things about kind of ways of supporting making connections. So the first thing is if we pay attention to our insecurities and cognitive distortions, notice what they are, we can then begin to challenge and question these thoughts to decipher if these insecurities or distortions are helpful or true. Most often they're neither, but it's good to ask yourself that question to work out the validity of the thought. So try not to compare yourself to others. This is something we all do, but it will likely increase insecurities as it's including a sense of judgment and expectation. And the expectation or judgment or thing that we're comparing ourselves to may be too high for the situation and not helping. Remembering that you are not invisible, but at the same time, people are also involved in their own lives, so they might not notice if you do end up doing something silly that you fear that you will, particularly if you're worried about being watched or judged, as the likelihood is they aren't thinking of it to the same extent as you are in your mind. Also, if you are silly, it could be an icebreaker anyway, and it's only normal. So the likelihood of you hitting it off with everyone is rare. You have to find your people. And remember, one bad social experience doesn't mean that it will be bad every time. We can often kind of take one thing like, oh, I tried, that's it, done my one. And often think, okay, that's it, I don't have to try it again. It didn't work that time. But that's not helpful because it doesn't mean that you're going to do the same thing every time. You might be different, the experience might be different, and the other person might be different. Another thing is to remember to prioritize your social life. It needs time put into it and to be put first. And like most relationships, it takes work and schedule and maintain. But that element of work doesn't mean that it's something that isn't fun. So how to make new relationships. So some kind of practical things that we can do. One of the things is to practice talking to strangers. There was a piece of scavenger hunt research which saw a reduction in people expecting to be rejected when talking to a stranger. It showed increased positivity of their conversational ability, feeling less awkward, and they noticed more opportunities to talk to strangers. This research prompted people to repeatedly strike up conversation with strangers each week, which ultimately reduced their fear in doing so. The research did show that this effort needs to be maintained. One single moment of talking to a stranger and having a pleasant experience does return us to our pessimism rather than if this is something that is maintained and continues to be done over a longer period. So repeated practice of taking the initiative to talk to strangers is crucial. So you might be thinking, how do I go up and just kind of start conversations with strangers? And there are some situations where it is a little bit more natural than others. For example, the hairdressers. I don't think I've ever been to the hairdressers and not had a conversation. Picking up daily groceries in the supermarket. Delivery people, servers in restaurants. You don't have to share your whole life story, but these are moments which build confidence and make it less awkward for the next time, or for a time where you are ready to make a more meaningful connection. Another thing is having open body language. This exudes confidence, like this person in this picture. It exudes warmth and a sense of invitation to engage. If you're sat in the corner, not looking at people, I'm not necessarily going to come over to you. I might not think you want me to. So it's make yourself seem approachable. Be a good listener. Make yourself somebody good to talk to and show that you're actively listening. People will talk to you if you seem like a good person to bounce off of and that they have your attention. Sign up for a class. There might be a hobby or something that you're curious of. And this starts you off already with a shared interest or experience with the people in the class with you. There's already something to talk about, very present in this current dynamic that can open that connection. Another thing which some people don't like to do, particularly, if you're out and about, but ask for help if needed. Don't be afraid to ask to be introduced to others. If there's someone and you're not good at remembering names or how to initiate, is ask them, can you introduce me to everyone when we go around? Things like that. Or to say that it's something that you struggle with and that you might need some help in being invited places or anything like that. I think people should only respect that from you. So another thing is to have a positive friendship narrative. This is a more constructive way of thinking. So to phrase your thoughts as, I can make friends if I try, rather than nobody likes me. That's not going to help you move forward. Another thing is to start an interaction with a high point. If you go in complaining about the weather or something else, although right now I am doing this, it's not going to make you the most inviting person in the room. Rather than if you go in with something lighter or more optimistic, it'll make conversation with you more appealing. Another thing is admitting struggles socially can make you more human and relatable. Saying something like, I'm a recovering awkward person. It's so nice to talk to you. Or, I don't really know what I'm supposed to say at these events. Do you find it a bit awkward too? It's a very present and relatable thing, and I'm sure lots of people, if not now, have had moments like that they can help support you with. Harness curiosity. The key is to be interesting and be interested. So ask questions, show that you're actively listening, and by asking questions, it'll only help you find things that you have in common more. Do not stand people up. If you find that you have made plans, go. If you don't attend last minute, it will make you less likely to be invited again. So if you are asked to attend something on the spot, pause, don't answer straight away. If you need a moment to go over it and think about whether that's something that will be doable for you, and let them know that you'll get back to them when you've been able to think about it. There's nothing wrong. They don't need an answer right then and then in that moment. It can wait. My personal favorite that I found online whilst preparing this webinar is apparently a good way to meet people is to host a brunch. I'm going to hand over to Stu now to think about polyvagal theory.
Thank you, Anna. It wouldn't be a webinar without a big scary chart, so I wanted to throw this in for you guys. But I think this is really helpful. In a minute, I'm going to talk about safe and sound protocol, which is an intervention to help people be more calm and present in social situations. But first, I want to kind of go over this. So this is a image here of your nervous system. okay? And this was developed by Dr. Stephen Porges, who developed Safe and Sound Protocol. And it's really important and pertinent for the conversation that we're having today. So at the bottom here, this is the state of your nervous system called the ventral vagal or safety state, right? That we can all connect to this, your parasympathetic nervous system. So whenever you're feeling calm, you're feeling connected, settled, grounded, and you're just generally open to social engagement, it's very likely that your nervous system is in the ventral vagal level of activation, okay? You're curious, you're open-mindedness. This state is associated with digestion, with rest and recuperation, health and vitality. Your immune system is active, and you're not very defensive. Your body's defense responses are inactive at that time. And so think about a time when you're, with a few close friends who you feel really safe with, you're in a casual environment, there's no observable threats or painful conversations, you're likely in your ventral vagal nervous system activation. Above that is going to be your sympathetic nervous system. So this is when we start to identify something in our environment is dangerous, and we start to become hyper aroused. This is the mobility stage of our nervous system, fight or flight, as we'll remember from our survival styles and personality, right? So fight is moving towards, that's rage, anger, irritation, frustration. Flight is panic, fear, run away, right? And this is where physiologically we're having an increase in blood pressure, we're having our heart rate go up, we have adrenaline spiking, our pupil size dilates, and essentially we're preparing for action. You'll have blood go to your limbs and you'll literally prepare for action. What's interesting about this stage is that socially, when we're in our sympathetic nervous system, we are not good listeners. We're not good at connecting, and we're not interested in supporting and being supported by others because we're experiencing a threat in our environment. At top is our oldest level of nervous system activation, which is the dorsal vagal level. This is like life threat. This is like, I might die, right? A grizzly bear has walked across my path. Maybe I'm in an experience where there's, a gun or something that, has the potential to end life. And this is really associated with immobility. So hypoarousal, a slowing down of the nervous system where we might literally faint. We might actually lose consciousness. We might dissociate. We might feel completely numb or depressed. And so just to note here that the social engagement system is our newest level of nervous system activation. And Anna, we can go to the next slide here. So what's really interesting is what they found is that individuals who have a lot of experience with trauma and also individuals on the autism spectrum, a big part of that nervous system activation. So how does your nervous system decide if it should be calm or if it should be sort of prepared for danger or if it should be prepared for a life threat is through your hearing and your middle ear, right? And there's things in our environment every day that are safety cues. So when someone talks with paucity of voice, when they're speaking in varying tones and a lightness to their voice, our inner ear and our nervous system, that's a trigger to say, oh, that's a safety cue. This is a safe person. I'm able to let my guards down. My nervous system can relax and I can listen to the content. I can be present with that person, right? But there's also noises that create us to go into our sympathetic nervous system. So think about like a low guttural growl from a dog or a predator, right? That's where this comes from biologically. You hear those noises, boom, sympathetic nervous system. You are no longer listening to the content that someone's sharing with you. Your blood is rushing into your vital organs and to your limbs. Like, I might have to fight this thing. I might have to run away. And what happens is that all throughout our days, we're experiencing safety cues and danger cues in our auditory signals. It also happens visually. But for the purpose of the Safe and Sound protocol, I want to hit the auditory aspect of this. So people who have long histories of trauma, over time, their middle ear gets trained to pick up on more danger cues and gets less skilled at picking up safety cues. So they might be in a social engagement with someone where they're getting safety cues. The person is demonstrating that they are safe to them and they're just missing it. So Safe and Sound protocol was developed as an intervention to help with this, as an auditory protocol where essentially you listen to music. You listen to 5 hours of music. Sometimes it's over 5 days, sometimes over 10 with a clinician. And the music has been distorted to essentially retrain your middle ear to be more skilled at picking up safety cues in the environment. And they have seen this be really, really effective with children on the autism spectrum, with people with post-traumatic stress, depression, chronic pain, fatigue, a lot of different ailments that are all sort of physiological in nature. And it really, really is helpful for individuals who may have a nervous system barrier to developing social relationships. Because as I mentioned, if you're in your sympathetic nervous system or your dorsal nervous system level activation, you're not building relationships. You're not connecting with other people because you're literally preparing for a threat rather than looking for connectedness. So safe and sound protocol is really, really easy to implement. You're able to just sit and listen to music while doing something passive. I just kind of want to note, it is not like a standalone therapy. You do need to kind of use it kind of in preparation with other trauma therapies. But this is definitely something I encourage everyone on the call to look into. If you notice that you have a very hard time calming down, if you notice that social interactions seem to get you almost on a physiological level, very activated, it may be something that helps. So with that, I'll toss it back to Anna to wrap us up.
Thank you, Stu. So before we conclude, I just want to go over how to support other people. So if you are someone that is more social, you could keep an eye for those on the periphery who might be struggling or presenting as if they are a bit shy. Engage them in small talk, show curiosity and be welcoming. Invite them out, give them some space to get back to you rather than expecting an answer right there and then. And maybe suggest an activity to do so that they know what they can expect when they are with you, as this will particularly reduce any anxiety. And you may have to continue to be the initiator of activities or conversations until they are comfortable doing so. And by extending invitations, you're still having the opportunity to expand your social network at the same time, while also being able to support somebody else. Another thing is to try not to take it personally if they do resist or decline support. Remember, despite how much you offer support and try to get someone out and to be social, it may not be their day to do so. Let them know that you are still there for them, offer to go to them or to be on another end of the phone. Sometimes support is being with someone rather than doing something with them, letting them know that you are there to be with them when they are ready or for whatever they may need. So to summarize everything that we've gone over today, social relationships can improve mental health and physical health and prevent loneliness. Social media, COVID-19, and different mental health diagnoses can be barriers to forming relationships. However, they also remind us of how integral those relationships are. We need to use trial and error to gain social relationships, to be open-minded, curious, make less assumptions, and be playful with forming and maintaining connections. There are methods we can implement for ourselves and to help others that we've also gone through today. So thank you. I'm now going to hand it back over to Amanda.
Yes, thank you both so much. I'm reading some of the comments in here. I think this was an excellent presentation, very educational, and I'm confident we could take several more webinars just on one or two of these topics alone, specifically safe and sound. I think maybe that's in our near future. So just to jump right into questions for the sake of time, as a reminder, we might not get to all questions today, but we will be following up in an email. As a reminder, when we're done with the presentation as well, you will need to complete the post-evaluation form. So please make sure to stay on. We will complete this presentation before the 1 o'clock hour. So to jump right in, Stu, you had referenced a TED Talk at the beginning. Can you confirm who that speaker was? There was a lot of curiosity around this.
And I put it in the chat. The speaker is Johan Hari. He has a really good book called Lost Connections that goes into this really in depth. But the TED Talk, I forget the name of the TED Talk, but if you type in his name, and I put it in chat and type in TED Talk. Oh, and thank you, Anna, for putting the references up there. It's easy to find on YouTube. The book is called Lost Connections.
Thank you so much. And just a reminder, everyone, you are getting a copy of this presentation following. So Stu or Anna, how are the needs of social inclusion met in an inpatient setting? How are they met differently in a mental health program versus a substance use disorder program?
Okay, thanks, Amanda. I can take that one. So I can speak to my experience at Cairn Renaissance and Cairn Florida Mental Health. So, one thing that is similar in both of those programs is that we are very, very big about encouraging the patient to develop a support system. So our model down here is really unique in that we actually really encourage our patients and clients to go off campus to participate in the local community down here in Palm Beach County. Through a pass system where they're able to go out with alumni and they're encouraged to go to the beach, get something to eat. Downstairs in the Renaissance program, a lot of that is like 12-step based, right? So they would go to 12-step meetings. And we really, really encourage them to not only have a community within their cohort, their peer group in treatment, right? But also to develop that with people that are a little bit further down the road, right? Who have developed, some serious stability in their mental health or substance abuse recovery. So we're very intentional in a lot of our philosophy and our practice in encouraging folks to not just sit in a treatment setting all day, to actually go out into the world safely. So that's certainly a big part of it. I think group therapy is a big part of it. A lot of patients, when they first come in, do not like group. They want individual sessions. Just that process is intimidating and scary. And in most cases, by the end of it, they're going, oh my God, I love group therapy, right? They want to be part of that. They want to relate and connect with each other with a skilled clinician kind of facilitating a discussion. So those are the main points. I think the main difference in treating a mental health population is that I think, with good need, you have to be a little bit more careful with a substance abuse population and how you're reintegrating them to the community, because there's the risk of relapse, right? There's the risk of them being exposed to triggers and alcohol and substances. And you can be a little bit more flexible with a mental health population. But the challenge that you have is that there are many mental health support groups, but they're not as easily accessible in some places. I don't think that's true everywhere. As compared to like a 12-step population, right? So in therapy, what you're doing with those people is you're talking about the fears and barriers to reintegrating into a group. These are people who have either completely avoided social interaction or have been using substances to numb their feelings with social interaction. So there's obviously a tendency a lot of the times to isolate. So a lot of the clinical focus is given to that person and supporting them through the discomfort while they reintegrate into the community.
That's right. Well said. Now, we will do one more question. Can you talk about strategies for engaging suicidal adolescents with substance use?
Yeah, sure. And Anna, feel free to jump in here. I think that obviously it's a marriage of family support and using a really skilled adolescent or family mental health professional. So I think the best things that family members can do to support adolescents, period, is just cultivate and really demonstrate, model emotional language. Processing feelings is something we're still learning to do as a culture. And I think that young people who watch their parents talk about their feelings and talk about solutions to those feelings, it helps normalize it, and it helps create a space for that person where they don't feel like what so many adolescents feel, which is, I'm the only one experiencing this. Right? Now, when you add in the complexity of suicidality, right, and substance abuse, where we start talking about safety, that may be definitely the time to include a professional into the conversation. And a really skilled professional with an adolescent is going to have the family super involved. So they're going to be able to kind of give recommendations about level of care, what type of support the person might need, but really just to be super mindful that this is already a person who is probably feeling like they're a lot more screwed up than everybody around them. So a lot of normalizing language can be really, really helpful, while also normalizing the process of asking for help, right? And I also think that, encouraging that young person to start talking about substance abuse and mental health, not in the context of being in trouble, right? Which is a challenge, obviously, because as parents, we do have to redirect behavior, and we do have to say, hey, these are the boundaries around your behavior. So finding that nuance can be challenging, but we certainly want to have, you do not want the, parole officer, inmate dynamic with your adolescent, because you want to encourage them to have a space to talk openly.
Absolutely. Thank you. Thank you, Stu and Anna. so much for this presentation and for all of our guests for joining us today. So just as a reminder, this is eligible for 1 CE credit. Watch your emails immediately as soon as we close. There will be a link from CE Go to complete your evaluation, and the slides and recording of the webinar will be emailed to you within the next 14 days. So Karen actually has several more exciting events in the future. I wanted to share real quick on October 4th. Please join us for another CE sponsored by Encore Outpatient Services. That will be called Bridging the Gap, an integrative understanding of substance use disorder and family system recovery. And then on October 19th, we are doing our 4th installment of the Countdown to Heal series, which is focusing on our new medical detox and medical stabilization services at our soon to open 100,000 square foot facility here in South Florida. That'll be next year. And then lastly, on November 4th, Karen is hosting our 7th annual Addiction Research Symposium, approved for 6 AMA PRA credit, Category 1 credits. They're both in-person and online opportunities, so we would love to have you. We'll send all the details in an email. In the meantime, feel free to reach out to your local regional resource director at any time for extra information, resources in your area, or questions about any admission to one of Karen's many programs. Thank you so much again for joining. For those in Florida, please continue to be safe, and we'll see you next time. Thanks so much. Bye.
Thank you.
Thank you.